Good afternoon, everyone. Thank you for being here. My name is Alqahtani. I'm an endocrinologist from Saudi Arabia. I'm currently in Vancouver, Canada for a one-year clinical fellowship. So today, in the next few minutes, I'm going to be talking about dynamic GMI. So we all know that with the CGM revolution, people started looking at GMI as a surrogate marker for A1C, not only by physicians but also by patients as well. And there are a lot of talks during this conference about the A1C GMI discordance, and we believe it exists, and it's represent a clinical challenge that we are facing on daily practice. So we at BC Diabetes looked at our data set. We have more than 3,000 patients using CGM. So we have large data. We looked at the data and we found that 35% of our cohort are having clinically significant or clinically meaningful discordance, meaning more than 0.5%. So in order to reduce that discordance and improve the reliability on GMI, we tried to improve that equation. And as you all know, GMI equation is basically a linear regression analysis that was conducted by Bergenstahl and his team. And we tried to come up with a new linear regression analysis equation, but we didn't really find significant difference, so the problem persists. So it seems like it's non-linear regression association that's happening. So we moved forward to more machine learning models. We use different models to address the collinearity. We looked at elastic net, exposed, and different machine learning methods. And there was a difference, but it was not that satisfactory to us, so it wasn't like that clinically meaningful. Then we moved forward and we asked this question: so what if the relationship between A1C and blood glucose is patient-specific? We know the glycation rate, the RBC lifespan is variable among people, so it has to be something patient-specific approach. So then why don't we leverage the past patient history in order to reduce that discordance? And that's what we did. So we looked at 50 patients with 3 A1C GMI pairs, and so dots and lines are colored by patients, 3 dots per patient, and the black line represents Bergenstahl GMI equation, and you can see the massive deviation in relation to Bergenstahl equation. So it's a clinical challenge. So zooming into one of hypothetical patients, Mr. John. So Mr. John started using CGM, and 90 days later he had an A1C done. And you can see the A1C result in relation to the GMI, that the dashed red line, that's the discordance. It's almost 1%. That is really significant. So sometimes later John had another A1C done, and the discordance even got worse. As you can see, the red dotted line and the blue dotted line. So then we used the previous A1C, the previous error or GMI error as the current A1C, as you can see the red open circle, and we saw significant improvement in the discordance, as you can see the small blue dotted line at number 2. So we developed with the help of our smart-based statistician a model that we call dynamic GMI that's leverage all these together. So the setup was we had more than 3,000 A1C GMI pairs for training purposes, so up to 3 pairs per patient. Then we had tested them on different people who are enrolled after that day just to avoid the bias. So we tested on 500 patients, and here is what we got. So the dynamic GMI was able to decrease the mean absolute discordance significantly. As you can see, in those people who have passed A1C GMI data, the mean absolute discordance was reduced from 0.43 to 0.36 overall. And that was driven mainly by those who have passed A1C GMI discordance. If we look at the proportion of patients with clinically significant discordance, i.e. 0.5 or more, the proportion was reduced from around 35% down to 14%. So almost more than half of people, we avoided the discordance using dynamic GMI. So translating this into relative risk reduction, there was 60% reduction 60% relative risk reduction in A1C GMI discordance if you use dynamic GMI. So this is a scatter plot showing the relationship between A1C and GMI. As you can see in the top central graph, you see how close the A1C GMI to each other and the relationship with our value of 0.93, and you can see the improvement compared to the other three models. So we looked at whether or not the timing of the past discordance will make a difference, and we didn't find any difference. So it doesn't matter what is the timing of the past discordance. It can be somewhere from just 1 day to up to 200 days. So this summarizes the dynamic GMI model. So in conclusion, so the relationship between blood glucose and A1C is highly heterogeneous across patients, and we believe that leveraging discordance data will improve and boost the GMI performance. Dynamic GMI, or we can call it error-corrected GMI, significantly reduced the discordance by over 60% compared to the traditional Birkenstock GMI equation. So again, GMI is equivalent to BC diabetes equation, which is our local linear regression analysis if there is no past discordance available. Future work may evaluate the incorporation of multiple past observations, because we have included only once, and also we will look at the 14 days versus 90 days just to make things easier for the calculation. And also we have developed a very simple, I know the equation looks very complex, but we have developed a very simple calculator that is available online. You can find the barcode on our poster, number 964. All what you need is you input your patient's 90 days average glucose, and if you have the A1C and the past A1C and GMI, just input it and it will calculate the dynamic GMI or the error-corrected GMI. So finally, I'd like to thank the great team for the great work, and thank you for listening, and I'm happy to take questions.